Welcome. Individuals from the boomer and greatest generation may, for example, if they were left-handed, have been forced to use their right hand for things, like my grandparents and my wife's mother. They were left-handed, but were forced by their teachers in school to use their right hand. This was seen by those teachers as quite important. This is what society demands of you, child, that you be like this. Sometimes, like in the case of left-handedness, what society demands of us is rather arbitrary. But of course, sometimes, as in the case of following the law, not touching others that don't want you to touch them, or meeting occupational expectations, in those cases, society demanding conformity or adaptation seem quite reasonable and perhaps our only option if we want to get anything done. Are you meeting, in a way that's healthy for you, the demands of your context? If not, what help and or changes in expectation should be forthcoming? Special education in Ontario. In Ontario, since December 12th of 1980, with Bill 82 being signed into law, school boards have been required to provide education to all students, regardless of any disabilities they may have. This bill, called the Education Amendment Act, came 5 years after the United States passed Public Law 94-142, the Education for All Handicapped Children Act. Before the 1960s, students, or potential students with disabilities in Canada, were generally served by residential institutions, such as schools for the blind. The recognized authorities in this case, since the disabilities were medical issues, were medical doctors. In the 60s, there was a shift to what was called the ecological model, or what most of us might call a holistic approach, where the insights of teachers were taken into account, and integration and normalization, i.e. inclusion of exceptional individuals in the normal classroom as much as possible, and looking after their needs, but not just their academic needs, their needs in general, was becoming valued. Bill 82 in 1980 noted, among other things, that all Ontario residents were entitled to publicly supported education. All school boards must have identification, placement, and review committees, IPRCs. Parents of children with exceptionalities must be part of the IPRC process and may appeal decisions. And boards must have advisory committees, plans, and procedures specified for special education. So, every student gets an education, without exception. In 2012, the Supreme Court of Canada affirmed this with the ruling that adequate special education is not a dispensable luxury. For those with severe learning disabilities, it is the RAMP that provides access to the statutory commitment to education. Note that this requires boards to educate everyone, but not necessarily to include everyone in the regular classroom. Each student with exceptionalities is to have their own individual education plan, IEP, and the specifics of the IEP are determined on a case-by-case basis. The default and the ideal is inclusion in the regular classroom as much as possible. And this is an ethic based not in charity, but in the rights of the individual student. Next, we will get into some diagnostic categories and criteria provided by psychiatry and psychology. The school boards in Ontario recognize 5 separate special needs categories. If a student fits any of these categories, Bill 82 and Regulation 181 require that this student receive an education and that there is a formal plan, an IEP specified for that student's education, their ongoing needs, and the ongoing assessment of whether this plan is effective. This is the general template that is to be followed for an IEP. You will specify students' strengths and needs. A strength might be something like he has creative ideas for stories. He can come up with lots of novel approaches or character names when prompted. And there's a distinction that may be disorienting at first down here, which is the difference between goals and expectations. Goals are broader, more global targets. So we're going to get the student better at working on math word problems, better at solving word problems, for example. Whereas expectations will be something more specific, such as the student will be able to recite the rules of subtraction. But this individualized education plan is to be filled out with the help of the parent or guardian of the child, and is to include a plan for follow-up. In addition to the reason for the development of the IEP, the student's profile, any relevant assessment data, their strengths, their accommodations, and how they have been and will be assessed and instructed. But the IEP is a rather living document subject to modification. And note that it's not an itinerary of specific things that the student's going to do each day. The goals and expectations don't go into that level of detail. Moving on. The disorders formerly known as disorders of childhood, now rebranded as neurodevelopmental disorders. Because they start in childhood, it's the responsibility of caretakers and educators to address these issues, to determine whether they are issues, whether a label should be affixed and benefits given, and the extent to which we can adjust society or a classroom to accommodate. We started with the idea, especially with intellectual disability, of it's like some people don't develop past a certain stage, like they're stuck in a younger stage. That's still a meme or an idea behind our thinking about neurodevelopmental disorders, like a delay, which was the meaning behind the word retardation. But
we're a bit better now at not expecting everybody to be near the center of normal on everything.
The general idea here is if you don't do something like engage with language by a certain age, you may lose your window to be trained in that specific skill. We'll start with intellectual disability because, roughly speaking, so did psychiatry. Intellectual disability, first off, is the term that the DSM-5 uses. The ICD-11 will call intellectual disability intellectual developmental disorder, which is why if you open up the DSM-5, you see intellectual disability and then in brackets after it, intellectual developmental disorder. So what are we talking about here? Intellectual and adaptive functioning deficits. The green is new, adaptive functioning deficits. Conceptual, social, and practical domains. These three separate domains. Usually starting before grade school. In other words, with intellectual disability, you usually notice it very early on. So what are we talking about with intellectual functioning? Can you solve problems? Can you reason? Can you make plans? Think abstractly? Here you see the influence of IQ tests. And can you make the correct forms of judgment? Like money. Can you be responsible for your own money? Can you be responsible for choosing your own meals? Adaptive functioning takes the intellectual side and throws it into context. How well do you actually do in terms of independent living? It's not abstract. I'm not extrapolating from an IQ test in terms of how well you solve problems. I'm actually seeing how well you're functioning in your actual life, how much help you're getting from other people, and how successful you are with or without that help. So can you participate socially and get what you need from other people with other people? It's no longer just a matter of, can you pass the tests? We're looking more at your actual adaptive functioning compared to the past. So let's go to the past, and let's take a tour of the past using as our guideposts the language changes that we have seen over the past 110 years. So 100 years ago, we had 3 different medical classifications for intellectual disability: idiot, imbecile, and moron. So if you had an IQ of under 75, you could be in any 3 of these bins. The idiot bin was an IQ of 0 to 25, the imbecile bin was 25 to 50, and the moron bin was 50 to 75. This is a quote from Goddard. Goddard was speaking in 1910, and he was inventing the word moron. So here we go. The feeble-minded may be divided into those who are totally arrested before the age of 3. So arrested, they're stopped. Their development stops before the age of 3, so that they show the attainment of a 2-year-old child or less. These are the idiots. Our IQ tests were, back then, based more on mental age than the deviation type of IQ tests that we have today. Okay, so that's type 1. He's describing idiots. So our IQ score of 0 to 25, you could, rather than map that onto an IQ score, you could map that onto age. So you're stuck. You don't develop past the age of 3. Whatever you can expect from a 3-year-old is the most you could expect from an idiot by this classification. Let's talk about the imbecile next. Those so retarded that they become permanently arrested between the ages of 3 and 7, these are imbeciles. So the most you could expect from someone with an IQ of 25 to 50 under this scheme is something that you could expect from someone who is 7 years old. And now the morons, those so retarded that they become arrested between the ages of 7 and 12, these were formerly called feeble-minded, the same term that's applied for the whole group. Well, you gotta do something about that. We are now proposing to call them morons. This word being the Greek for fool. The English word fool, as formerly used, describes exactly this grade of child, one who is deficient in judgment or sense. All right, so here you go. 1910. It's Henry J. Goddard speaking to National Educational Association of the United States. How long did it take? From 1910, we invent the word moron as a medical psychiatric classification in order to, rather than just say that everyone is deficient if they're pre-age of 12 in terms of the expectations we would have for them, rather than just call all of them feeble-minded, we will make a special class to kind of recognize that the moron class is the upper crust of feeble-minded. It is not created as a term with ill intent, but how long does it take society to pick up this brand new term, realize that they can use it as an insult? It takes 12 years. According to Etim Online, which is also where I grabbed this quote from, it took 12 years. So by 1922, we had examples of moron being used as an insult. So then we have to change our terms. By the time 1952 came around, we were avoiding idiot, imbecile, and moron, although there were remnants of the prefix idio in the DSM-1. But we changed our terms to mental deficiency. And that doesn't seem great, but that's the language change because moron is an insult now. So IQ, if you have an IQ of less than 85, then you qualify as mentally deficient. If you are in the mild category, which is by far the majority of cases under this scheme, which has been changed obviously since, severe mental deficiency would have been imbecile or idiot level. We avoided the word moron because it's an insult, and then the word mental deficiency is suggestive of a negative judgment as well. So when the DSM-2 comes around, even though there's not too much happening in terms of regime change, we still decide we're going to come up with a better term rather than mental deficiency, one that is less judgmental. We're going to call people mentally retarded. And again, this was a generous term. Retard means to hold back, like the retarding fins on a plane's wing. That's all it means. But society picked it up, and now you can't use this term in legal documents in the United States anymore, for example. The IQ cutoff didn't change, but the sub-bins changed. We created a borderline mental retardation classification, mild, and then moderate, and then severe, and then profound. Profound was less than 20 IQ points. So now we have the term mental retardation, again, as a replacement. Come DSM-3, when so many other big changes were being made, now we have the improvement. Borderline mental retard classification was pulled out of the mental retardation category. So we were left with mild, moderate, severe, and profound, but we created a second classification, which is borderline intellectual functioning. So it's no longer a part of mental retardation, or MR, which if you work in the hospital, that's what you'll hear it called. You'll hear it called MR. That's what it'll say on the charts, MR. And then DSM-5 came along in 1994. We were still diagnosing people with mental retardation, but once again, we changed the subtypes to absorb the fuzz in measurement. Back in DSM-3, we added into the description that you should allow for plus or minus 5 IQ points of measurement error / clinician judgment. We know that IQ tests have a test-retest difference of maybe 5 IQ points. So that means that somebody could reach the cutoff, but it could be within error measurement of the test. So the clinician gets kind of 5 IQ points to do what they want with, so that you could score 74, but rather than throw you in borderline intellectual functioning, if I see that you're really hurting, challenged by your state, well, then I could throw you in the mental retardation bin. So it's 1994, and we're still using the mental retardation term, and even with this cutoff, nearly all the cases we're seeing are mild. The more extreme the score, the rarer it is. In the U.S., in legal documents, you can't use the word mental retardation. This was called Rosa's Law. U.S. President Obama signed it into law in 2009 that they would change all of their references to the words intellectually disabled and intellectual disability. DSM-5 followed suit, and Canada is following suit as well. It was in 1993 that the Ontario government passed Bill 4, which removed the term trainable retarded from the Education Act. That's not because there was any ill intent behind the term. That's not because the classification of individuals with comparatively low intellectual functioning is inherently a bad thing. It's because society picks up these words and then they have negative connotations. I think that's one of the reasons why we're getting more
syllables in our descriptions. Intellectual disability is not a good insult. It's not like moron. It doesn't just roll off the tongue. So DSM-5, we have intellectual disability, open bracket, intellectual developmental disorder, close bracket. What are our IQ cutoffs for our mild, moderate, and severe and profound? We got rid of the IQ cutoffs. We're not emphasizing IQ as much anymore, although in order to have an intellectual disability diagnosis, you do need a standardized assessment. It's just your level of severity, and now, formally, you need to show adaptive functioning, not just a low IQ score. What you need to show is you need to show the individual across their ability to conceptualize, their ability to socialize, and their ability to engage in practical tasks. At the conceptual domain, we see that your challenges are more severe if they were more noticeable at an earlier age. It would look like you get stuck at about age of 3 if you are 5 years old and you are still behaving like a 3-year-old. If you will only get stuck in the 7-year-old stage, well, we're not going to notice you getting stuck in the 7-year-old stage until you hit 7, right? So more severity would be indicated by the problem being noticeable earlier. Is your thinking more concrete? Do you need things physically in front of you, or can you abstract words and concepts? And how much assistance do you need in order to work with ideas and solve problems? So that's the conceptual domain when we're assessing level of severity. So you have a more severe intellectual disability if your challenges were noticeable at an earlier age, your thinking is more concrete / less abstract, and if you need more assistance to accomplish conceptual milestones like school tasks. How about in the social domain? You have a more severe intellectual disability if you are less able to read social cues, if you are less mature in responding to these social cues. In other words, are your emotional responses appropriate, tuned into other individuals? Here we have language. Someone who is higher functioning in the intellectual disability range would be able to write. Somebody who is less high functioning would probably have the ability to speak clearly, but not necessarily write clearly. And then when you get into the more severe range, then you have an inability to articulate verbally, maybe just your nonverbals or how you're communicating, pointing. And now the practical domain. What types of tasks do you need help with? Figuring out the bus schedule, following an itinerary or a list. Say you need to take a certain bus to the grocery store and then only get items on your list. Do you need help with that? Well, that's kind of a complex task. Or do you need help with something like cooking, depending on the meal, but let's say it's a simple meal. Do you need help with that? Or do you need help with getting dressed? Do you need help bathing yourself? How complex are the tasks that you appear to need help with in your daily life? Another question is, how vital are the tasks that you need help with? Sure, if you need help to cook a fancy dish, it's unfortunate, but it's not vital. If you need help to clothe yourself, help to make rent payments, this is a little more vital. There's also, in the practical domain, recreation. Do you have fewer hobbies? Are your hobbies simpler? Do you need help with these simple hobbies? Intellectual disability is not prevalent in Sunnybrook Hospital. We'd have lots of individuals who the kids would come in at age 6 and we'd see it in their records. We would see global developmental delay. Global developmental delay just means we think that the individual has an intellectual disability, but we were unable to perform any standardized tests. If the kid is under 5, that makes sense. Oftentimes when we see global developmental delay, the kid ends up being fine. Where you need a better excuse to have not completed a standardized test is with unspecified intellectual disability, which is the category we use when you have not completed standardized testing, but you're still pretty sure that the individual qualifies for intellectual disability diagnosis. Specify here why the test was not completed. Why didn't you run a Wechsler IQ test? Classic communication disorders, a language disorder, you're not good at picking up vocabulary and you use words incorrectly, you don't structure sentences correctly. Another aspect of this is a challenge with discourse, figuring out what the other person needs from you based on what they're saying, figuring out how to respond to that constructively. Maybe you just have a speech sound disorder. We tend to see what are called the late 8, the sounds that developmentally kids tend to get the latest. We really don't expect kids to be reliably using these different sounds so that others can understand the difference until they're around 7. I'm going to get my 2-year-old to say these. Can you say zoo?
Zoo.
Can you say lake?
Lake.
Can you say rake?
Rake.
Can you say think?
Sink.
Can you say this?
This.
Can you say shovel?
Shovel.
Can you say measuring tape?
Measuring tape.
We missed S, but hopefully that reminds you that these sounds need to be learned.
Okay, stuttering falls under communication disorders. Most people recover from stutters. Stuttering involves both the halting type of stuttering, where it's like a tip of the tongue and you're just kind of trying to push it out. A stutter can also be a prolongation of a single sound. Then we have a brand new category for you called social communication disorder. Pragmatic communication disorder is another term for it. So if you have all four of the following, then you qualify for a social communication disorder. You have trouble with greetings and with the sharing of information. As a kid, I really had a hard time with the idea that when somebody asks you, how are you, they don't really want an answer. People are fine with not answering the question. So greeting and sharing information, figuring out what people need from you, giving people something that they need emotionally. Matching communication to context or to the listener. Context could be as simple as inside and outside. Do you use your inside voice outside so that I can't hear you because you're too quiet, or are you using your outside voice inside such that it's very loud and people are looking at us and it's strange? Another context is the person to whom you are speaking. You should speak to a child, a young child, differently than you would speak to an adult, your boss differently than you would speak to a coworker. Do you pick up on these cues of what these different types of people need or what a different context calls for? Do you pragmatically have a sense of this and then follow through? Do you have trouble taking turns? Somebody doesn't understand you. Do you throw it back on them? Why don't you understand it? Or do you say, okay, well, what does the person need that they're not getting, and can I rephrase it so that they get it? Do you use nonverbals? In order to find out what something actually means, people need to see the emotional valence for it. Could you be any louder? Could you be any louder? And what your body does gives the meaning to the words. The words can mean the opposite thing if your body is doing something different when you say them. All of this would add up to create a fourth problem, but the fourth problem is a separate diagnostic item. Do you have trouble making inferences from limited information? Because that is what we do. Nobody presents a full logical argument in the real world. It's all what Aristotle called enthymetic arguing, meaning our premises and the actual structure of our argument is mostly hidden. We're relying on people to know what we mean and to fill in the blanks. Do you have trouble doing that? Do you have trouble with idioms, phrases that don't necessarily make sense literally? So if you hit all four of these, then you have this new disorder called the social communication disorder. Next, motor disorders. Are you particularly clumsy such that you either fall frequently and or have trouble relatively simple tasks like using a fork or doing up laces or buttons? Clumsiness is right in the description. Clumsiness as well as slowness and inaccuracy of performance of motor skills. Stereotypic movement disorder, self-stimulation type of behavior. Maybe you're dealing with anxiety in a way that helps you take control of it. We're going to specify whether it is a self-injurious subtype. Are you physically harming yourself, or is it just a behavior that you seem stuck in? Stereotypic movement disorder is diagnosed if it is your sole problem. If there's a larger syndrome associated with it, then you may be getting into the territories of autism or impulse or conduct disorders. Tic disorders. First off, what's a tic? That's a sudden, rapid, recurrent, non-rhythmic motor movement or vocalization. So either physical movement or vocalization. If you have had a tic for a year and the onset for the tic occurred before the age of 18, then you qualify for a tic disorder. For Tourette's, you need at least 2 motor tics, maybe a facial tic and a shoulder tic, and then you need at least 1 vocal tic as well for a year more, and it started before you the age of 18. Attention deficit hyperactivity disorder. We're hoping to make it less prevalent as the changes to the DSM-5 take effect. The majority of cases are male. There is a bit of sex difference in terms of the presentation as well. Females tend to have more intense attentional deficits. They also tend not to have the hyperactivity subcomponent. Males tend to have the hyperactivity subcomponent. An individual with ADHD runs the risk of engaging in risky behavior even throughout adulthood. They are at risk for landing in a lower socioeconomic status bracket. ADHD is most comorbid with oppositional defiant disorder and conduct disorder. Those are not neurodevelopmental disorders. They are disruptive impulse control and conduct disorders. That's the heading for that category, that's ODD and conduct disorder. What does it take to get an ADHD diagnosis? It's 2 separate disorders. Criterion A, persistent pattern of inattention and or hyperactivity impulsivity. So the impulsivity, it seems to have the most in common with disruptive impulse control and conduct disorders prospectively. It interferes with functioning or development as characterized by 1 and or 2. 1 is the attentional subcomponent and 2 is the hyperactivity component. But what that or is telling you is that you can have ADHD with no attentional deficit or with no hyperactivity. What do you need then? This is the inattentive subtype. 6 or more of the following symptoms have persisted for at least 6 months to a degree that is inconsistent with developmental level and that negatively impacts directly on social, academic, occupational activities. This phrasing is supposed to secure us against pathologizing childhood. I can't fault you for being a kid, but I can fault you for being a kid who acts like a less mature kid would act. That's the idea here. We have to rule out oppositional behavior, defiance, hostility, failure to understand tasks or instructions. Often fails to give close attention to details or makes careless mistakes in schoolwork, at work, or during other activities. Often has difficulty sustaining attention in tasks or play activities. Often does not seem to listen when spoken to directly. Often does not follow through on instructions and fails to finish schoolwork, chores, or duties in the workplace. So undone tasks everywhere. Something that the parents at Sunnybrook would tell me is they would find half-completed homework sheets. Often has difficulty organizing tasks and activities, managing sequential tasks, keeping materials and belongings in order, messy, disorganized work, poor time management, fails to meet deadlines. The Connors tests and the Achenbach copy and paste and modify these items. What we'll do is we'll have a checklist for the teachers and we'll have a checklist for the parents. Mom will fill it out, dad will fill it out, teachers will fill it out, and then we'll get a sense of how much the symptoms deviate from what's expected for their age group. Because we'll ask questions like, how much is this true of your child in the past 6 months? How much does your child have difficulty keeping materials and belongings in order? To what extent would you describe your child as messy? So we give these to a bunch of people whose kids don't have ADHD. They give some answers. We compare clinical cases to these norms. What this does is hopefully ensures us against just pathologizing normal types of behavior. But it also creates a problem of creating a bell curve, and whenever you create a bell curve, there are most extreme scores. So anything that makes a bell curve also makes the abnormality that it seeks to find. Often avoids, dislikes, or is reluctant to engage in tasks that require sustained mental effort. Often loses things necessary for tasks or activities. This is another thing that the parents will tell me. She keeps losing her school books, she'll lose her glasses, I gotta tie things to her if I want her to remember to bring them home. Is often easily distracted by extraneous stimuli. A lot of questionnaires for parents and teachers just copy and pasted this verbatim, as if the average schmo is going to be able to read this sentence and not think 3 times about what it means. Extraneous stimuli. Is often forgetful in daily activities, doing chores, running errands. If you had 6 or more of the inattentive subtype, then you already qualify. You already qualify for diagnosis of ADHD. Hyperactivity and impulsivity. Often fidgets or taps hands or feet or squirms in seat. Often leaves seat in situations when remaining seated is expected. This is a nightmare that I have with some kids at age 6 and some kids at age 11 and 12. They can't sit still for the hour or 2 of testing. Often runs about or climbs in situations where it's inappropriate. Often unable to play or engage in leisure activities quietly. Often on the go, acting as if driven by a motor. Here's another one that gets copy and pasted onto every ADHD checklist. Often talks excessively. Often blurts out an answer before a question has been completed. Often has difficulty waiting his or her turn. Often interrupts or intrudes on others. Let's say you met criteria by having 6 of one column. What you need is to establish, and this is new, what's in bold is new, you need to establish that the symptoms are present in more than one setting. This is where we're trying to reduce overdiagnosis of ADHD. We don't want to give them a diagnosis just because they hate school. If they have trouble at school and they have trouble somewhere else, at work, at grandma's house, at home, next you need some sort of adaptive functioning to be harmed, and then you have to rule out other disorders. Let's say you met 6 of inattentive or 6 of hyperactivity. You get to assess whether you had a combined presentation, 6 in one and 6 in the other, predominantly inattentive, 6 in the inattentive subtype, but didn't have 6 in the hyperactive subtype. Maybe you had 0, maybe you had 5, or you could have predominantly hyperactive/impulsive. So you give them stimulants. Ritalin. In the 30s, we had tested something called Benzedrine. Astonishingly, by 1937, amphetamine had also been shown to be an effective treatment for hyperactivity in children. Charles Bradley gave Benzedrine to a group of severely disturbed children and reported beneficial effects. quote, to see a single dose of benzodrine produce a greater improvement in school performance than the combined efforts of a capable staff working in a most favorable setting would have been all but demoralizing to the teachers, had not the improvement been so gratifying from a practical viewpoint. In other words, they would have been insulted by the fact that drugs could do better than their efforts if they weren't so happy that the kids were finally behaving themselves. Individuals with ADHD are calmed by the stimulants, whereas someone without ADHD, if they get activated, behave more hyperactively than otherwise. So in normal children, you're going to get more hyperactive if you take a stimulant, but with ADHD children, you calm down. For the inattentive subtype, there's less of a case that you are treating something that's biologically unique as opposed to just giving them something to enhance their performance. The ADHD brain does look a little bit different, a bit less brain activity. This is where the stimulus hunger hypothesis comes from. Stimulants help to reduce hyperactivity because hyperactivity is a response to the brain's need for stimulation. The brain somehow knows that it's understimulated, and so it says, hey, body, go and do stuff, stimulate me. And if you give exogenous stimulants, then it's satisfied, and so it doesn't tell the body to be hyper anymore. We observe a lot of labeling, pathologizing in school settings. You are labeled as obstreperous, refractory, you experience frustration of your goals, and you see yourself frustrating others who want you to sit still, they want you to stay on topic, they want you to focus. So you may have the issue of identifying with or as this challenge. So maybe you see yourself as deserving of shame, somehow insufficient because you can't behave according to expectation. That dovetails very nicely with the social level of observation, which says, well, okay, if we were out in the forest chopping wood, or collecting berries or hunting rabbit or something, I imagine that the individual with ADHD would probably be happy and fine, and they might even be amongst the best of us, presuming that they could get home from the hunt. The idea then is, well, what's causing ADHD? Some kind of abnormality that you need to fix, or society moving in away from these individuals who represent this part of our biological heritage. Yeah, it's advantageous. If you think of us radiating out of Africa, if one group was hit with famine or disease and they died out, well, the human race survives because you had other humans in other pockets that did survive. If society changed its expectations, if we stopped having kids sit in school, maybe things would be different. Moving on, a specific learning disorder.
Ontario school boards refer to these as learning disabilities, and they're a challenge with learning or with the use of information in a specific area, rather than a more global problem, as the case with intellectual disability.
Difficulty learning and using academic skills. We're generally looking for specific decrements. Difficulty learning and using academic skills as indicated by the presence of at least one of the following symptoms that have persisted for at least 6 months, despite the provision of interventions that target these difficulties. And this is where some people ridicule the DSM a little bit, because you're admitting that help is ineffective. So inaccurate or slow and effortful word reading, difficulty understanding the meaning of what is read, difficulties with spelling, difficulties with written expression, difficulties mastering number sense, number facts, or calculation. Do you use your fingers rather than memory? Yes, I do. Do you have a problem with that? Difficulties with mathematical reasoning. Any one of those could be a problem. You need the affected academic skills to be substantially and quantifiably below those expected of the individual's chronological age and cause significant interference with academic or occupational performance or with activities of daily living as confirmed by individually administered standardized achievement measures and comprehensive clinical assessment. Alright, so you gotta hit all of these boxes. You need the difficulties to begin during school age years, and you need to rule out other categories. What are our main specifiers? Impairment in reading, and then you have subtypes: word reading, reading comprehension. Dyslexia falls here. Specific learning disorder with impairment in written expression, spelling, grammar and punctuation, clarity or organization of written expression. Specific learning disorder with impairment in mathematics, number sense, memorization of arithmetic facts, accurate or fluent calculation, and accurate math reasoning.
There are plenty of psychoeducational assessments that we use to determine whether someone might have a specific learning challenge. I have not used all of them. Different professionals have different preferences. I will take us through this test. the wide-ranging achievement test. This is the test that I took as a homeschooler and a test that I administered as a psychometrist at Women's College Hospital and Sunnybrook Hospital.
I was homeschooled up until grade 11, so in order to keep the state happy and so that people wouldn't take us away, my mother would have us do the wide range achievement test every year so that we had documentation that we were keeping up with things. It is based on grade level. You get to do spelling tests and comprehension tests, assess whether you are up to grade level. Word reading. Pertinent to impairment in reading, it has a word reading subtest and a sentence comprehension subtest. Pertinent to impairment in written expression, it has a spelling test. Pertinent to impairment in mathematics, it has a math computation section that goes from very simple addition to dealing with long division and fractions. So, impairment in reading. What type of questions are on the RAT test that assess impairment in reading? You have a word reading subtest. Can you read these words? Go ahead, try to read this. Can you read this word? Can you read this word? It's not a visual acuity test, it's a pronunciation test. Have you seen these? Do you know this? Did this one catch any of you? I get some kids saying Rankid. I have plenty of kids saying Denny. They haven't been exposed to deny. Kids saying Regime or Regum. Most of the kids don't make it this far. Inefficacious. I think this one will stump you. Say out loud what you think this is. It's synecdoche. My wife and I use synecdoche with our boys. As shorthand, we'll just call them big and little. I could say, I will hold the big child, but instead I just say, I'll hold big. And then she'll say, I'll hold little. That's synecdoche. When you use part of a descriptor of something as a description of the whole. Some items that assess sentence comprehension. Carlos began to lag behind Tricia, who walked much too blank for him. Can you fill in the blank? Now, of course, this is comprehension, so I'm not reading this to the child. They are reading it themselves. And often the difficulty doesn't come from the thematic content, but from the length of the words or the infrequency of the words. Rare words make the question harder, so a lot of kids really have trouble reading all the way through this one, and some will just guess. In ancient cultures, members of the ruling family wore unique garments so that people could blank them from others at first sight. I've had incorrect answers, including take. Could take them from others. Mountain. The next word is mountain. The mountain road is steep. Mountain. That's an actual item from it. And when they look like they're done writing. The next word is kitchen. Our kitchen is very small. Kitchen. Impairment in mathematics, math computation. Questions look like this. Can you answer this question? How about this one? Solve for X. These are the types of questions. The idea being, with specific learning disorder, that if you score really high in spelling and word reading and sentence comprehension, but really low in math, then you are not up to your own standards. Now, you should also be scoring low in math for your grade level, so we're not just pathologizing you in one thing based on your high performance and other things. So if you have at least a standard deviation below average, a math computation score, but you're scoring high or normal in other things, then maybe you have a specific learning disorder impairment in mathematics, or what we call mathematics disorder. In order to get the diagnosis, we also need to specify that prior extra help with mathematics has been unhelpful. Autism spectrum disorder. There's two big themes to autism spectrum disorder. First, deficits in social communication. You need to establish for diagnosis all of the following, either from interacting with the kid or from history as told usually by the parents. Deficits in social emotional reciprocity, give and take. Deficits in nonverbal communicative behaviors. Do you give people what they need? Deficits in developing, maintaining, and understanding relationships. Shared imaginative play, interest in peers. Do you start to enter the mind of the other, or are you kind of stuck in your own? The big referent here is social referencing. So social referencing kind of encompasses all of this. If you're interacting with someone with autism, what will be off is their social referencing. So things like eye contact, things like looking at the person. If this is absent, you will notice. Also, early on in the process, you can falsify a potential diagnosis of autism, because we'll get a lot of probable autism or something in their chart to that effect. That the kid's making good eye contact, they're giving back what we give to them in terms of emotion and content, they're focusing up. Usually you can tell pretty early whether you're going to get a be a confirmation or not, just from social referencing. But it's a very wide spectrum. Restricted, repetitive patterns of behavior, interests, or activities, as manifested by at least two of the following. Stereotyped or repetitive movements. This could be rocking, this could be hand moving, head moving. Insistence on sameness. A piece of furniture has been moved or removed, and maybe they'll just have a breakdown about it, big emotional breakdown about it, maybe even harming themselves with repetitive movements because of this change to their environment. Highly restricted or fixated interests. The classic example is trains. Hyper and hyporeactivity to sensory input. A child with autism staring at a light. Maybe the light has them transfixed, so that would be kind of over hyper reactivity. You could have hyporeactivity as well. Maybe you're more resistant to pain. This is the criterion that once you've seen it in an individual's autism, you realize that autism is actually something quite special. Restriction of interest. What you'll see is perseverative thinking. That one thing is stuck, and that one thing is going to be manifested in all of the other things that they're doing. One test that I give to kids in Sunnybrook Hospital is, I draw a vertical line. Can you draw down there what I draw up here? They'll do it, and then I draw a horizontal line, then draw a horizontal line, then draw a circle, and then they do their best to draw a circle. I was doing this with an individual who ended up with a diagnosis of autism. There was one shape, and it was 3 circles, like a Venn diagram, but with 3 circles, and they all overlapped a little bit. It was so sticky that when I turned the page and I had all these new shapes, triangles and overlapping rectangles, underneath these other shapes, they just kept drawing the 3 circles. The 3 circles, the 3 circles, the 3 circles, the 3 circles. I was allowed to ask whether what they drew is the same as what I had. They said, yeah, it's the same. So I don't want to continue the test. So I said, okay, well, let's do something else. And then one thing that we once in a while do, not because it has any diagnostic value, is we'll do a draw a person test. Draw a little boy, draw the best little boy you've ever drawn. Take as much time as you want. But guess what the person drew on that page rather than the best boy that they'd ever drawn? They drew just a whole bunch of 3 circle patterns, 3 circle patterns, 3 circle patterns, 3 circle patterns. The kid just got stuck on these 3 circles. So that's perseverative thinking. It's like a micro version of the need for sameness. So you need symptoms to be present in the early developmental period. It's clinically significant impairment. The autistic spectrum is very wide. It ranges from individuals who are very high functioning, highly intelligent, who just have a little trouble picking up on the underlying emotional tones and rhythms of conversation, and they're probably fixated in their interests, so they end up doing quite well. Lots of inventors and scientists are believed to be on the spectrum, believed to have been on the spectrum. You range from that to individuals like the individual that my friend is tasked with taking care of. She is responsible for helping him through his school day, and he is going through puberty, so he's getting stronger. And one thing that she has to do for him is she has to help him use the washroom, so she wipes him afterwards. But sometimes he doesn't like that process, so she has to wrestle him to wipe him. He's quickly becoming stronger than she is. This is the width of the spectrum. You have very different types of individuals. It encompasses different types of disorders. With Asperger's, you tend to not see any early speech delay. In fact, you could see the opposite, individuals being precocious readers and reading very early. Now, most of the new cases of autism spectrum diagnoses have average intelligence, where that wasn't the case before. Autism spectrum is a chance for behaviorist therapy to flex its muscles. This is what works, intensive behavioral intervention. The clinic needs your kid for at least 20 hours, but it's generally expected that they get 40 hours of specific training and attention. So maybe this is rewarding kids for eye contact or for verbalization. You're trying to shape the behavior. The intent here is not necessarily to make the child normal or to shape the child externally. The idea is, especially with social referencing, that if the child gets enough experience looking at other people and interacting with other people and gets potential to engage with the minds of other people, the idea is that this is going to be rewarding in and of itself for the child. So you're opening them up to another thing that they can become interested in, other people, to start the process of engaging. We're trying to change from the inside out, where we're trying to show the child what there is to be interested in. And so we're shaping the social referencing and social engagement so that they can hopefully pick that up on their own and run with it. With the neurodevelopmental disorders category, most of these disorders, most of these cases are not cured or fixed or recovered. They're just kind of part of the diversity that we have as human species. With the neurodiversity movement, we have the idea that helping someone improve their life and making someone more normal are not the same thing. The idea is to figure out how we can help an individual, or maybe just get out of a person's way, but how we can help an individual to have the opportunity to engage in a meaningful way and get what they want in life, despite the fact that those around them expect something different than what they have.
So take yourself as you are, and instead of expecting yourself to be perfect.
It took a while for Bruce to get what the coach was driving at.
Okay, that's enough for now. Stay tuned.